So I just have a few quick announcements. This is a sort of a rapid-fire, quick-paced thing, so all the presenters, we're going to keep you your time. I have a few housekeeping notes we want to do. One, remember the exhibitors out there, we want to support them. They support the meeting, so please make sure you visit them. There'll be a coffee break at the end of this session, so go out and visit the exhibitors. The next thing is a special announcement that was announced earlier today. The Midwest Vascular is going to support for the Journal of Vascular Surgery case report. So any of these presentations gets presented today, there's a cost to submit it to the case report to JVS, and the MVS is going to support that and financially support the cost of contributions. So anybody who has a case presentation today who thinks it would be a great thing for the Journal of Vascular Surgery case reports, please submit it, and the MVS is going to support you and pay for the payment and the accepted publication. And then last but not least, I want to remind the students that at 2:45 is the live hands-on session. And without further ado, let's get started. The first speaker, I'd like to introduce the topic is a novel approach to aortic endarterectomy with ultrasonic aspiration. This will be presented by Joshua Burke from University Hospitals at Case Western in Cleveland.
Thank you. Good afternoon, ladies and gentlemen. We have nothing to disclose. Aortic atherosclerotic disease most commonly affects the infrarenal aorta. In rare cases, the suprarenal aorta can be affected with extensive, dense, exophytic, and calcified disease that leads to aortic occlusion. This is colloquially referred to as coral reef atherosclerosis. If untreated, this can result in renal hypertension or insufficiency, mesenteric ischemia, lower extremity ischemia, and congestive heart failure. Transaortic endarterectomy is a classic primary mode of therapy. However, not all coral reef aorta is amenable to endarterectomy due to the plaque wall erosion and adventitial thinning. Thoracic aorta-based bypass grafting can be utilized, but it is invasive and requires extensive exposure, operative times, and the need for prosthetic materials. An alternative approach to transaortic endarterectomy is ultrasonic emulsification and aspiration technology. The Sonopet ultrasonic aspirator employs a proprietary technology that combines longitudinal vibration and torsional oscillation for precision in carving calcified structures while leaving the surrounding soft tissues unaffected. The efficacy of ultrasonic emulsification aspiration has been reported in other fields of surgery, historically in dentistry and craniofacial surgery. It has been successfully utilized in cardiac surgery in patients with severe mitral valvular calcification who are too high risk for mitral valve replacement. We have successfully employed ultrasonic emulsification aspiration of the paravisceral aorta in 3 patients, and I will be presenting a representative case. This is a 59-year-old lady with severe uncontrolled hypertension on 7 antihypertensives with lower extremity rest pain. She presented to the hospital with acute kidney failure and flash pulmonary edema, necessitating intubation and hemodialysis. As you can see in the CTA, she had coral reef atherosclerosis starting at the descending thoracic aorta and extended all the way to the occluded infrarenal aorta. After extensive discussion, the decision was made to proceed with ultrasonic emulsification aspiration as a last measure. A 9th interspace thoracoretroperitoneal approach was used, and she underwent ultrasonic emulsification and aspiration of the coral reef aorta, including the orificial lesions of the visceral vessels using the Sonopet. The aortotomy was primarily closed, and aorta bifemoral bypass graft was completed. The visceral ischemic time was 31 minutes. She was extubated on postoperative day number 1, and the rest of her course was uncomplicated with recovery of her renal function to normal baseline. She was discharged home on postoperative day 7. At her 3-month follow-up, she was doing extremely well with no claudication symptoms, and she was only on 2 antihypertensives with widely patent paravisceral aorta and visceral vessels as noted on the CT scan. This is especially appreciable when you compare the post-op CT on the right to the preoperative on the left. To quickly conclude, we present the first use of ultrasonic emulsification aspiration in aortic surgery. There are 4 main advantages to this technology. First, it enables plaque removal. Second, it mitigates the risk of developing dissection flaps. Third, it serves as an excellent alternative to thoracic aortic-based bypass grafting and avoids a prosthetic conduit. The potential pitfall is over-aggressive use of this technology, which can lead to adventitial thinning and put the patient at risk of hemorrhage.
Based on your experience, do you have any tips for finding the sort of sweet spot between leaving disease behind and thinning things out?
Yeah, I think in the cases that we've done successfully, the key is, I think, in most of the authors' experience is to err on the side of actually leaving some disease behind and not trying to get too aggressive. You don't want to leave it to that perfect, where it looks absolutely perfect. You just want to be able to restore patency of those visceral vessels and leaving a little bit more disease behind.
Okay.
I think it's a pretty ingenious idea. Keep going next.
Okay. Thank you for your presentation. Our next presenter will be Dr. DeRue from the University of Wisconsin. She is going to talk about endovascular strategies in diagnosis and initial treatment of vascular quadrilateral space syndrome.
Perfect. All right, thank you so much for the opportunity to present our case report on quadrilateral space syndrome and endovascular strategies to treat it. A 21-year-old right-hand dominant female patient presented to sports medicine clinic with the chief complaint of right arm pain with numbness and tingling in her hand. She was a collegiate volleyball player. Her pain originally developed while performing a plank position for training. After being referred to sports medicine clinic by her trainer, she was found to have a cool hand with ischemic changes to the digits. We suspected arterial thoracic outlet syndrome, and so a CTA was obtained which showed no evidence of arterial TOS. Clot was, however, noted within the radial and ulnar arteries. She was urgently referred to vascular surgery clinic. Her exam was notable for a palpable radial pulse, pallor, and coolness to her third digit. Normal motor and sensory exam were performed. Our differential included arterial thoracic outlet syndrome, which seemed unlikely in the setting of our CTA, and quadrilateral space syndrome. We recommended inpatient admission for IV anticoagulation and diagnostic versus therapeutic angiogram with possible thrombolysis. In the OR, we began with a right upper extremity angiogram via a groin approach. Thrombus was noted within the posterior circumflex humeral branch, 1 centimeter past its takeoff with distal reconstitution. Thrombus was also noted within the forearm vessels. We administered 2.5 milligrams of TPA into the radial, ulnar, and interosseous arteries. Angiography was performed in provocative positions, arm at rest and elevated, with no impingement noted. We prepared for a right upper extremity cut down under general anesthesia. We performed an axillary cut down within the anterior axilla at the inferior border of the pec major. We identified the axillary neurovascular bundle and dissected out the posterior circumflex humeral artery for sufficient length to allow ligation, which was performed with a silk proximally and distally. A good signal was noted in the axillary artery at case conclusion, and she had a palpable radial pulse. She was discharged on postoperative day 1 on a DOAC, with plan to return to clinic serially for evaluation over the next 2 months. Her WBI and postoperative duplex were reassuring, with intact motor and sensory function and no concerns for digit ischemia on exam or WBI. At the 2-month mark, she was cleared for return to play after 48 hours off of Pixaban. Vascular quadrilateral space syndrome is a rare disorder involving compression of the posterior circumflex humeral artery within the quadrilateral space, which is bordered by the teres minor, teres major, long head of the triceps, and humerus. Repeat overhead trauma can cause thrombosis or aneurysmal degeneration of this branch. Symptoms include those of acute ischemia, muscle atrophy, weakness, and pain over the quadrilateral space. Rarely does thrombosis propagate to occlude the axillary artery. Diagnosis is confirmed by imaging, with DSA being preferred, specifically an external rotation and abduction to reveal compression within the quadrilateral space. Treatment is with ligation to prevent distal embolization, with acute thrombotic complications managed by thrombolytics. Our patient, fortunately, was not only able to return to play, but furthermore be named National Player of the Year. It was a pleasure to be able to help an athlete return to playing the sport they love. I'd be happy to take any questions.
I think this is a really rare diagnosis. I've actually never heard of it. What do you think the incidence of it is? Because for repetitive sports, what do you think the incidence of that is?
Yeah, there's pretty limited data. There's a case report of 9 patients with quadrilateral space syndrome, with not all of them even having the vascular variant of it, some of them having neurogenic. I think that probably there are people who have it that just have it silently and aren't diagnosed. There was a study of about 300 elite volleyball players, and at about 5% of them, there were aneurysms at this branch that were noted.
That's probably underdiagnosed. Thank you so much.
Yeah, absolutely.
Great presentation.
Thanks, Dr. DeRue.
All right, thank you. Our third presenter is aberrant right renal artery perfusion from right internal mammary artery, an unreported variation, presented by Dr. Patel from University Hospitals, Case Western Reserve University.
Thank you, everyone. Good afternoon, everyone. Thank you for the opportunity to present this unique case. We have no relevant disclosures. As you all know, that renal perfusion is very variable with the number and location of renal arteries. They typically arise from persistence of mesonephric arteries as kidneys migrate from pelvis to their adult anatomic locations. Majority of these aberrant renal arteries are identified incidentally. This was a 29-year-old male who initially presented with accelerating hypertension and microscopic hematuria. He had, on exam, acrodactyly, hyperflexibility of certain joints. A renal artery duplex demonstrated bilateral lesions with aneurysm and stenosis. This was concerning for non-atherosclerotic renal artery disease. He had also underwent genetic testing, which demonstrated a mutation in the collagen 4A3 gene, which was consistent with Alport syndrome. Here's a CT, the 3D re-rendering of the CTA. As you can see, there's multiple renal arteries bilaterally. There was a left superior renal artery which had severe proximal stenosis with a 2-centimeter poststenotic aneurysmal degeneration. And the right renal artery, the superior right renal artery, as you can see, was being perfused by a network of collaterals that could be traced back to the right internal mammary artery. We performed an angiogram, and as you can see here, there was asymmetric filling of the right kidney compared to the left. Upon cannulation of the right internal mammary artery, you see a filling of this network of collaterals overlying the diaphragm, which then ultimately perfused the upper 2/3 of the right kidney via a large collateral, what we presume to be the right inferior phrenic artery. And again, the image on the left demonstrating the superior left renal artery aneurysm. We were worried that this patient was hypoperfusing the majority of the right renal parenchyma, and we were worried this was resulting in renovascular hypertension. And we performed Renin sampling from the right renal vein, and it confirmed our diagnosis of renovascular hypertension with a ratio of 11. After a multidisciplinary discussion, we took the patient to the operating room and performed open reconstruction of bilateral renal arteries via standard midline laparotomy. The image on the left here demonstrates the proximally occluded superior right renal artery and that large collateral coming from superiorly which was likely the right inferior phrenic artery. And on the left, we see the aneurysmal degeneration. We performed the aorta to right renal artery bypass using a 6-millimeter Dacron graft, and for the left renal artery aneurysm, we resected and performed a primary anastomosis. The patient had a relatively uncomplicated hospital course, went home on postoperative day 5. The pathology was concerning for intimal hyperplasia, which was consistent with a variant of fibromuscular dysplasia. The duplex at 6 months showed patent bypass with no stenosis, and patient was weaned down to a very low-dose single-agent antihypertensive. This case, to our knowledge, is the first, is a unique case demonstrating right renal perfusion via REMA and inferior phrenic artery collaterals. Again, in an era of endovascular interventions for renovascular hypertension, open operative interventions is still necessary from time to time. Thank you, everyone. I'll take questions.
It's a very interesting case. Did you do any exploration for other signs of FMD since your path showed this?
We did. We performed a CTA of head and neck and all the way down to pelvis. We did not find any evidence of other signs of FMD. Possibly we concluded this may be just a focal type of FMD.
Great. Thank you very much.
Thank you.
Our next presentation is entitled Rescue of a Misplaced Iliac Stent Using a Stiff Wire Loop Technique in a Patient with Phlegmasia. This will be presented by Paulina Villanueva from The Ohio State.
Hi, everyone. Thank you very much for giving me the opportunity to speak to you all today. My name is Paulina Villanueva. I'm a PGY4 integrated vascular surgery resident at The Ohio State University. My patient is a 79-year-old male with a past medical history of May-Thurner syndrome who had previously undergone iliac vein stents for May-Thurner syndrome and recurrent DVTs. He was on Xarelto. He presented with phlegmatious cerulidolens dolens to the emergency room after discontinuation of Xarelto for hematuria. You can see here the CT scan that we obtained in the emergency room. Upon review of the CT scan, we were concerned that the stents appear to be misplaced, and more concerning, they appear to be discontinuous from one another. And then on the other side, you can see the patient's leg up presentation. We took the patient to the operating room and we obtained femoral venous access as well as IJ access and shot a venogram. This demonstrated that the stents were in discontinuity with a stent from the proximal common iliac vein going into the hypogastric vein, and then an occluded external iliac vein stent, which essentially was gelling the external iliac vein. To the right of the screen, you can see a cartoon representation of the patient's anatomy as well as the stents. We attempted to cross the lesion using a glide wire. Unfortunately, the glide wire was penetrating the stent proximally, going in between the stent spaces. So after several attempts, we brought a stiff wire with a floppy tip. This was a Meyer wire. We were able to cross the occluded external iliac stent and create a big loop, which allowed us to pass parallel to the proximal stent without penetrating the proximal stent. We then brought in a snare and we performed a body floss technique. And again, you can see a cartoon representation of our technique for this case. We then deployed a biobond stent against the existing bare metal stent, which allowed us to establish inline flow between the external iliac vein and the IVC. And then to the right of the screen, you can see a reconstruction of Terra Recon that demonstrates the location of our stent at the completion of our stenting. We then perform mechanical thrombectomy as well as a completion venogram, which you can see here. We have inline flow between the external iliac vein and the IVC. And we were lucky enough to see the patient in follow-up with the CT scan, which demonstrated patent stents. So my conclusions for this case are as follows. Passage across a misplaced stent or a crushed bare metal stent can be very challenging. Your wire can penetrate the stent inner spaces. In this case, a stiff wire with a floppy tip passed outside of the proximal stent without entering the stent itself, allowing us to reestablish continuity between the two stents. And again, here I have a cartoon representation of our technique as a summary. Thank you very much. I'll take any questions.
Yeah, I think that's actually really a problem. You know, actually, I noticed more and more from arterial work, people are doing kissing stents right now. They're up high enough, it's very hard to get up and over. So you sort of had endotrash, right? You went outside the stent, used a covered stent, and was there any concern that the bare metal, the stent would actually rip through the vein? I guess you had a Viabond to protect it.
Yeah, so
that'd be my worry.
the common iliac vein to the hypogastric was patent, and so we were trying to preserve pelvic outflow, and so we wanted to keep that open. And so, like you said, that was a possibility. Obviously, anytime you're using a loop, but our Viabond was there to protect us in case we got into some trouble.
Great presentation.
Thank you.
Thank you.
Okay, our next talk is on Eagle syndrome complicating a carotid, and it will be presented by Lewis Nelson from the Cleveland Clinic and in Akron.
All right. Good afternoon, everyone. My name is Lewis Nelson. Again, I'm going to be presenting a case on Eagle syndrome, how it complicates carotid. This was performed at Cleveland Clinic General with Dr. Lauren Masterson. All right, so case presentation was a 73-year-old male who originally presented to our vascular clinic due to carotid artery stenosis. He was previously admitted to the hospital due to dizziness, altered mental status, and TIA. At that time, he actually had a CTA that showed greater than 70% stenosis of the right proximal internal carotid artery by NASIC criteria. When we were reviewing the images in clinic prior to seeing the patient, we noticed that there was an enlarged styloid process that was superficial to the right carotid artery that was not identified or read on the radiology report. So we referred our patient to plastic surgery for potential resection of this enlarged styloid process. During the interview with the plastic surgeon, the patient actually related oral facial pain with chewing that would be so great that we'd actually have to place his hand into his head to manipulate his neck in such a way that the pain would resolve. Given the carotid artery stenosis, the location of the elongated styloid, as well as the pain syndrome, patient agreed to proceed with a combination case with plastic surgery and vascular surgery for resection of the elongated styloid and carotid endarterectomy. So here we have pictures showing the axial view on the left side, showing the styloid process that is just superficial to our carotid artery plaque. Again, we have the sagittal view showing where the styloid process is in relation to the styloid and carotid artery, as well as the bony reconstruction on the right side showing this large multi-segmented styloid process. So we elected to proceed with operative resection of the styloid process first. We began with a oblique right cervical incision paralleling the anterior border of the sternocleidomastoid. We carried this down until we were able to identify the submandibular gland. We then carried this inferiorly until we were able to identify cranial nerve 12. We then were able to see our styloid process going superiorly and inferiorly to its proximal and distal origins as highly accessible as we could get. We noticed it was multi-segmented and it was about 5 centimeters. We then performed our resection, ensuring that we had lingual nerve and hypoglossal nerve identified and preserved. So looking at the photographs here, the upper left picture is just our preoperative planning for the incision. Then we have our resected bony specimen, as well as the intraoperative picture showing the retractor underneath where our elongated styloid is. Then we have the digastric muscle tendon, the stylohyoid muscle, the hypoglossal nerve, and you actually can see a clipped branch of the external carotid artery right below the bone. Then we moved on to performing the carotid endarterectomy in standard fashion. And then we, post-operative care, he was taken to the CVICU as standard protocol. Post-operative day one, he was discharged with neurofunction intact. 2-week follow-up, was doing well, did not notice any other pain syndromes, and had a well-healed incision. Plan for continued surveillance going forward. So.
Wow, that was remarkable. I noticed on your cross-sectional image there didn't appear, it wasn't the same level, but didn't appear to be disease on the other side. Do you think there was a mechanical causing?
He actually had a carotid endarterectomy on the other side years ago, and they didn't actually notice the bone elongation on that side too. On the other side, there was an elongation of the styloid. It just wasn't as significant.
I got you.
I noticed you had like a multidisciplinary approach, which is good. So what was the role of plastic surgery in this? I might have called ENT because they do a lot of the, I'm just wondering.
So they were the ones who basically were able to perform the first neck dissection with us and actually resect the styloid bone. That was just the care that we have at our hospital is plastic surgeries who helps with that it was a tumor resection expert.
Excellent. That makes sense. Thank you so much.
All right, thank you. Our next presenter, Dr. Daniel Gage from the Ohio State University, discussing postpartum problem, open repair of a dissecting AAA shortly after giving birth.
All right, my name is Dan Gage. I'm a third-year general surgery resident. Thank you for the opportunity to present today. Our patient was a 27-year-old female G5P5 with no significant past medical history who presented to an outside hospital with a chief complaint of abdominal pain. Approximately 1 week prior to her presentation, she had had a transvaginal delivery of a 39-week old fetus, which was complicated by fetal demise. She did present early in her post-delivery period with complaints of severe back pain 2 days following her discharge, but she was subsequently discharged from the emergency room at that time, but then came back and re-presented with continued back pain that was radiating to her abdomen. On the left, there's a representative CAT scan image what was obtained at the outside hospital. As you can see, she has a large dissecting infrarenal AAA with extension into the left common iliac artery. She was transferred emergently to our facility and was evaluated by our team. Given the concern for pelvic vascular exposure in the early post-gravid uterus, we did consult our OBGYN colleagues, given the concern for the need for a possible hysterectomy to complete the procedure safely. We proceeded to the operating room and proceeded with an open approach. We obtained supraciliac control and distal control with caudal retraction of the uterus. An initial Fogarty hydrogrip clamp was applied to the suprarenal aorta, but was deemed to be insufficient at that time. And given the patient's young age with concern for a possible connective tissue disorder as the etiology of her aneurysm, an additional clamp was applied inferiorly to proceed safely. Bifurcated Dacron graft was then applied to the right common iliac artery and the left internal iliac artery, and an additional jump graft was taken from the main body of the graft to the left external iliac artery. A hysterectomy was not required. This is another CTA following her procedure. As you can see, all the limbs of her bypass are patent, and then on the right there's a reconstruction from that same CAT scan. The patient had no immediate postoperative complications and was discharged on post-op day 7. Her repair and bypass remained patent. She has since had another child as well as another recent miscarriage, unfortunately. She has undergone genetic testing to look for connective tissue disorders, and there's been no clinically relevant genetic mutations that have been identified as the etiology of her aneurysm. Some specific considerations for this case: the patient did require an urgent surgical intervention. She had a symptomatic aneurysm with concern additionally on her scan for some fat stranding, possible impending rupture. Given her age, the consideration between open repair and EVAR was thought about at that time. Given the short aneurysm neck as well as the aneurysmal degeneration of her common iliac artery, she was deemed not to be as strong of a candidate for EVAR. Additionally, the need for long-term surveillance and more durable repair with a possible connective tissue disorder. And then the early post-gravid uterus, potential exposure difficulties did require us to talk to our OBGYN colleagues just to make sure that we had the right teams on board in case that we needed to do a hysterectomy. Thank you.
It's really an interesting case. Thank you. Given her young age and the development of this dissecting AAA, what's the plan to surveil her with?
Yeah, so in her subsequent pregnancy, she did undergo a CTA in her third trimester. Our OBGYN colleagues had developed a plan, and actually the particular specialist sees a lot of patients with connective tissue disorders and has various surveillance techniques. So patients with connective tissue disorders will sometimes get surveillance every trimester in the form of ultrasounds. MRI in this setting isn't very diagnostic, so otherwise they'll do CTAs in the third trimester.
Great, thank you.
Thank you very much.
Thank you.
Our next presentation is entitled 55-year-old female with enlarging pseudoaneurysm of previous aortic coarctation repair and previous ruptured pseudoaneurysm. This is being presented by Abdul Kader Natour from the Mayo Clinic.
Good afternoon, everyone, and thank you for the opportunity to present. We don't have any disclosures. Our patient is a 55-year-old female who presented with a progressively enlarging distal aortic anastomotic pseudoaneurysm. She had a history of aortic coarctation causing middle aortic syndrome with atresia of her celiac and SMA and bilateral renal ostial stenosis. In 1979, she underwent a supraceliac to aortoiliac bifurcation with a 24mm Dacron, in addition to bilateral renal artery bypasses using saphenous vein conduits. She was lost to follow-up until 2010 when she presented with ruptured pseudoaneurysm of her distal anastomosis, which was repaired emergently with a 24mm Dacron interposition graft. Patient is an active 1 pack per day smoker, has a history of CAD, stage 2 CKD, and after her vascular surgeries she had in 2013 open ventral hernia repair with mesh placement. This pre-op CTA shows patent thoracoabdominal aorta with absence of the celiac and SMA, patent aortic graft, distal pseudoaneurysm, and patent bilateral iliac arteries. This illustration summarizes the pre-op imaging and shows patent supraceliac to aortoiliac bifurcation bypass, ectatic bilateral renal saphenous vein grafts, large IMA which provided the entire mesenteric arterial supply, and pseudoaneurysm at the distal anastomosis measuring 8 cm, more than 2 cm from what it was 1 year prior to presentation. Given that the patient had multiple redo-laparotomies in the past and had open abdomen, we elected for a stage approach with the first day patient undergoing a redo-laparotomy with extensive lysis of adhesion and removal of ventral hernia mesh, as seen in this picture here. She underwent temporary abdominal closure, and then the next day the cardiac team performed a redo sternotomy, and then we opened the abdomen again, exposed and controlled the aortic bypass graft, the pseudoaneurysm, IMA, and the bilateral common iliac arteries. Our cardiac team initiated cardiopulmonary bypass and performed a 1-vessel cabbage. We then, under cardiopulmonary bypass, proceeded by clamping the bilateral common iliac arteries and the IMA. And then we placed the aortic cross clamp on the aortic graft, Dacron, just above the pseudoaneurysm. We entered the pseudoaneurysm and showed complete disruption of the anastomosis, as seen in this picture here. We cleaned up the tissue and then beveled and sewed the existing 24mm Dacron in an end-to-end fashion to the healthy portion of the distal aorta and right common iliac artery. And then we trimmed back the left common iliac artery to healthy tissue and then sewed an 8mm Dacron in an end-to-side fashion to the 24mm Dacron. Patient was weaned from cardiopulmonary bypass. Postoperatively, she had ventilator-associated pneumonia with worsening respiratory function, necessitating VV ECMO and tracheostomy. She then did better. She was decannulated from VV ECMO, tracheostomy, and was discharged home on post-op day 37. This CT scan was obtained 1 month after surgery and showed intact reconstruction. And at 6 months, patients doing well with improved kidney function and follow-up aortic duplex showed patent graft without recurrence of her pseudoaneurysm. Thank you, and happy to take any questions.
Wow, that's an interesting case. I also congratulated you on getting general surgery to start that case for you.
Yep.
I love that. But I also wonder, what do you think the etiology of these recurrent pseudoaneurysms are?
So we believe that the disruption in the anastomosis happened in the anterolateral portion of the repair, so we believe that the bites were not taken full thickness. So that's why we think the pseudoaneurysm happened and progressed.
But it was never angioplasty or anything like that?
So no, we got actually a PAT before proceeding, and it was negative for any kind of infection.
Dr. Milner.
I just had one comment. Wow.
Right. I was going to say, is there an endovascular approach to that? No problem. I know, I looked at it. I don't think it could be right.
Thank you.
Yeah, thank you.
Great.
Okay, our next talk is on infrarenal aorta to superior mesenteric artery bypass for Nutcracker syndrome in the setting of duplicated inferior vena cava by Yun Dong.
Good afternoon, everyone. My name is Jiang Dong from University of Minnesota. I'll be presenting infrarenal aortic SMA bypass for Nutcracker syndrome in duplicate in IVC. So patient presentation, this is a 26-year-old female with no significant past medical history except complex history of MALS, treated with the laparoscopic and open radiomedian arterial ligament release and celiac nerve plexus division in 2019, followed by 2022, and also celiac stenting at outside hospital. She presented our hospital system with a new onset lower abdominal pain and fullness, left-sided more so on the right side, in March 2023, severely affecting her daily life and job. Given her history and symptoms, we got a CTA. It showed a severe compression of left renal vein by SMA, and then duplicate IVC was also noted. So we performed the venogram for the patient, and we revealed a duplicate IVC with the left IVC draining through the left renal vein, and there are collaterals in the pelvic area around the L5S1 level from the left-right draining. And then pressure gradient across this left renal vein was about 5 millimeter mercury. So we decided against doing a left renal vein transposition in this case because the left IVC was draining mainly through the left renal vein. So we initially did a venous-venous bypass using cadaveric graft from left IVC to right IVC. The patient had a relief of her symptoms while the bypass was open, but this eventually thrombosed after about 4 months. So after a long discussion with the patient, because it was a redo laparotomy and then there's no previous data, we proposed the infrarenal aorta to SMA bypass to relieve the extrinsic compression on the left renal vein. Patient agreed to proceed because of her daily life symptoms. So we did a redo laparotomy, and then there's a left renal vein we inspected first to make sure it's not scarred down. It was normal and was not scarred down. So we dissected SMA like at its origin, and then we bypassed from the infrarenal aorta to the SMA to relieve the extrinsic compression in the left renal vein. And there was excellent graft pulse and Doppler signal at the mesentery at the end of the case. And the patient did well postoperative and discharged, tolerating regular diet. And this is a 1-month mesenteric duplex. You can see that there's a good flow through the SMA without evidence of stenosis. You can note that there's a flow in reversal in the proximal bypass portion going away from the probe, and then in the distal native vessels going into the probe. And then this is a 3 months 3D reconstruction of the aorta and then SMA. You can see the SMA taking off infrarenally and then going up and down into the SMA with no significant stenosis. Thank you.
Yeah, I had one question. You know, a lot of times when you're doing an SMA bypass, you know, you worry about kink, especially the vein graft. Was there concern about, you know, the angulation? Because when the SMA comes down, you worry that the graft may kink, or was that discussed or thoughts?
Yeah, that was discussed pre-op thanks to Dr. Omni, who's been experienced with the open stuff. So we kind of saw intraoperatively to make sure that it was laying down without a kinking, and then It was kind of
I guess it didn't look sort of straight there. You were
Yeah.
trying to get like a C-loop.
kind of C-loop, yeah. It was kind of guesstimate without specific measurements, but it worked well. Yeah.
Did it give you more hesitation to do this case, given that she has a celiac stent that's already needed to be relined? So now you've got her mesenteric circulation hanging off a relined stent and a bypass?
Yeah, I mean, there was definitely our worry, but after a long discussion with the patient was having severe symptoms, so we bite the bullet and then went ahead, and thankfully it's been working okay so far.
Well, I hope that keeps going. That's great talk.
Right. Thank you so much.
Our next presenter is Dr. Megan Perot from the University of Iowa, discussing hybrid approach for repair of traumatic pseudoaneurysm of the innominate artery in a pediatric patient.
Good afternoon. My name is Megan Parrott. I'm the second year vascular surgery fellow at the University of Iowa, and today I'm presenting a hybrid approach for repair of a traumatic pseudoaneurysm of the innominate artery in a pediatric patient. A 17-year-old previously healthy male was encountered after a motor vehicle collision. At the scene, his GCS was noted to be 3, and he was subsequently intubated. Shortly thereafter, the patient suffered PEA arrest due to ongoing hypotension and hypoxia. Return of spontaneous circulation was obtained. A chest tube was placed to evacuate hemothorax. He was then transferred to our facility for higher level of care. He suffered polytrauma with traumatic brain injury, rib fractures, pelvic fracture, pulmonary contusions, and multiple solid organ lacerations. Our team was consulted for a 2.4 centimeter pseudoaneurysm of the origin of the innominate artery. You can see the pseudoaneurysm here on the axial imaging, as well as on the sagittal view on the right. He was placed on anti-impulse control. However, due to his traumatic brain injury, he required hypertension to optimally perfuse the brain. He went into acute respiratory distress syndrome, thus open repair was not considered. On hospital day 8, he was cleared for operative intervention as well as heparin administration, and he was taken for repair. We accessed both from the right brachial artery via cut-down technique and from the left femoral artery percutaneously. The pseudoaneurysm was carefully selected from the groin access with the use of a prograde microcatheter, and then a 10 by 29 VBX was placed from the brachial access to exclude the pseudoaneurysm, and the microcatheter was then used to embolize the pseudoaneurysm with detachable terumas or coils. An Armada balloon was then used to profile the VBX stent. However, this resulted in loss of proximal seal due to shortening of the stent graft, so a second stent was then deployed and profiled. Our completion angiogram showed successful exclusion of the pseudoaneurysm. The patient had a long hospitalization complicated by veno-venous ECMO for continued ARDS, MSSA bacteremia, and an empyema whose cultures resulted with both MRSA and cryptococcus. Throughout his 4-month stay, his antibiotic regimen was changed multiple times with the assistance of transplant infectious disease. He ultimately left the hospital on day 102 of his stay with plans to complete 6 weeks of antibacterial antibiotics and a total of 6 months of antifungal antibiotics, which was completed 4 months after his discharge. On follow-up, the patient has recovered neurologically and continues physical rehabilitation. His repeat imaging at 1, 3, and 6 months showed no endoleak with maintained patency of the stent graft. Thank you so much for the opportunity to share this case. I'm happy to take questions.
I really enjoyed that. I think, that's a great example of, when I was training, it was open, but here you have these blunt trauma using endo as it may be a bridge if the patient's young to another procedure, right?
Mm-hmm. Absolutely.
And you're lucky that, because it's right below, because I was wondering, because you could do kissing stents there, I'm like, how are you going to get out? Because you had a seal zone right below where the anomaly.
Because it was very close to the origin of
that's a good example of endo to bridge, right? Because that open would never work. Dr.
That's
Milton?
correct.
Just yell.
Nobody wants to hear you?
Just yell.
Oh, man.
All right, hang on, I'm going to try this again. There we go. I have a mic and no music. Now we're all right. I actually had a similar thought to what Dr. Vogel was saying. I mean, obviously your solution here to get out of a really challenging problem with an endovascular approach is amazing.
Right.
But hopefully this person has X amount of years to live, and probably that is not going to be the X amount of years to live solution. So when are you planning on going back to do the next step? Because I think the problem is if you wait till there is a problem, when there is a problem is going to be catastrophic.
That's a very good question, and actually something I'll bring back to my staff, because we really do need to start considering when he's a little over a year out now from that initial repair. He is still completing rehabilitation, and I think once he's a little bit stronger, we can probably start talking about a repair and get the assistance of cardiothoracic surgery as well. But thank you so much for your question.
It's also a great presentation on why teenagers shouldn't be driving.
Thank you so much.
Don't tell that to my 7-year-old. Now, our next very good. Our next presentation is entitled Superficial Temporal Artery Pseudoaneurysm After Blunt Traumatic Injury. This is going to be presented by Dr. Sharma, and he comes from St. Vincent Hospital in Toledo.
Good afternoon. Thank you very much for giving me the opportunity to present a case of superficial temporal artery pseudoaneurysm after a blunt traumatic injury. We had a 73-year-old male with a medical history of atrial fibrillation on Eliquis who presented to the emergency department after a fall where he hit his head at the corner of a desk and came in with a swelling over the left frontotemporal region. At the time of presentation, his examination showed that the swelling was non-pulsatile. A non-contrast CT head was done, which just reported it as hematoma overlying the left frontal bone. He stayed in the hospital for control of his blood glucose and was discharged on hospital day 3 without any change in the examination of the swelling. However, he represented to the emergency department 10 days post-injury with complaint of persistent swelling and pain over the left forehead. At this time of when the examination was done, it has changed. The change was that it has become more pulsatile at this presentation. A CTA of head and neck was done, which showed superficial temporal artery pseudoaneurysm at this time. As you can see on the sagittal image, pseudoaneurysm, and similarly on the axial image. So a plan for repair of the pseudoaneurysm was made, and a detailed discussion was held with the patient. Eliquis was held for 24 hours, and the patient was taken to the operative room after getting informed consent. Intraoperatively, a duplex scan was done, which showed pulsatile flow with extensive hematoma. Doppler mapping was also pursued to delineate the superficial temporal artery feeding into the pseudoaneurysm. Incision was made over the pseudoaneurysm, and hematoma was evacuated. Bleeding superficial temporal artery branch was ligated. At the end of the case, hemostasis was adequate, and incision was closed with sutures. His post-operative course was uneventful, and Eliquis was started on post-operative 1. He was discharged on post-operative day 2. During the follow-up, images were shown on the screen. He had complete resolution, wound healed adequately. Superficial temporal artery pseudoaneurysm is a very rare clinical entity. On review of literature, I could find that only 400 cases have been reported. Most common etiology is blunt traumatic injury. Also has been reported in sport injury, also called as a puck aneurysm in hockey. It usually presents with a solidly palpable pulsatile mass, can be associated with complications including hemorrhage and skin disc necrosis. Treatment usually includes open repair and ligation, as was successfully demonstrated in our patient. Thank you very much. I will be happy to take any questions.
Very well done.
Thank you.
Okay, on to our final presentation for this session. It's a rare case of left ovarian vein transposition in a patient with Ehlers-Danlos syndrome. It'll be presented by Dr. Ashton Wilhelmsdotter.
Okay, great. Can I get the notes as well? Am I able to get the notes on the screen? Oh,
Maybe
thank you.
move the slide one.
Just one? Okay.
Just go forward. No, they're not.
No.
Yep.
Okay, thank you. I have no disclosures.
Oh, both.
Sorry. Just no. Thank you. Perfect. Thank you for having me and this opportunity. Okay, they're not connected. Still not seeing the notes. Good thing I'm the last one.
You're doing great.
Try to flip forward one.
Oh, thank you. Great. Okay. Venous compression syndromes have various clinical presentations and are often misdiagnosed, leading to delay in treatment. Nutcracker and May-Thurner are two examples wherein the vein is compressed by a high-pressure arterial vessel. Pelvic congestion syndrome is often associated with Nutcracker syndrome and less commonly May-Thurner, resulting in gonadal vein reflux, pelvic varicosities, congestion, and pelvic pain. The most common procedure used to treat Nutcracker has been left renal vein transposition. However, literature reports have demonstrated left ovarian vein transposition to be a safe alternative approach. While there are a vast number of reports and guidelines in respect to connective tissue disorders and arterial pathology, there is scarce information related to venous pathologies. There are rare case reports suggesting that a cumulative effect between these venous pathologies and Ehlers-Danlos syndrome leads to inferior postoperative outcomes. However, there's no current literature reports of Ehlers-Danlos in patients who related to a left ovarian vein transposition. So our patient was a 24-year-old female. She has a complex medical history, including what I've listed below or above, and including Ehlers-Danlos. And she presented us with left flank pain, hematuria, as well as pelvic heaviness and pain that worsened with her menstruation. We did a CT scan. You can see there's some compression of the left renal vein, as well as a dilated large ovarian vein up to 10 millimeters. We performed a venogram, which confirmed a dilated left ovarian vein with reflux, as well as a pressure gradient greater than 3 up to 4. We also, in case planning, deciding whether or not we could perform a minimally invasive approach using the left iliac vein, performed a IVUS of the left iliac vein, which showed moderate external compression concerning for May-Thurner syndrome, although she was asymptomatic from this standpoint. So we decided to perform a left ovarian vein transposition to the infrarenal inferior vena cava. Postoperatively, she had significant pain relief from her Nutcracker and PCS symptoms and did well. In conclusion, left renal vein transposition has been the mainstay of treatment in Nutcracker, but has several disadvantages, including the need for a large open abdominal surgery in a population of relatively young patients, as well as the limited length of the renal vein for relocation, and then subsequent complications such as bowel obstructions. Alternative procedures have been suggested, including left renal vein to splenic vein and proximal gonadal vein to inferior mesenteric vein bypass. However, these procedures also involve complex mobilization of veins. Left ovarian vein transposition has been reported as a simpler technique with minimal mobilization and also can avoid a large open procedure, especially if you use the iliac vein. Literature reports demonstrate this technique to successfully relieve venous hypertension in Nutcracker by redirecting the outflow through the left ovarian vein, also reducing pelvic congestion. There have been reports of successful left ovarian vein transposition, but this is the first case in a patient with Ehlers-Danlos. This case highlights the lack of consensus in the management of major venous pathologies in patients with connective tissue disorders.
Any questions? Okay, we have one. What type of Ehlers-Danlos does she have?
That's a great question. She did not have the gene for the vascular type, but no specific genetic type.
I would have said that was a really great operation for somebody if they had vascular Ehlers-Danlos to do a vein transposition. But another question, Greg.
I just want to make a comment. We've had several cases of the Nutcracker syndrome, and we're seeing more and more of these patients showing up with hypermobile Ehlers-Danlos syndrome with multiple compressions, and just wanted everyone to be aware of that they'll show up with MALS, SMAS, nutcracker, pelvic congestion, and May Thurner, as well as thoracic outlet syndrome and POTS. And these patients are, when you first see them, it's sort of unbelievable because of all these rare diseases, but in fact, it's a sort of a more and more increasingly common finding that we see in our clinics.
Thank you.
Thank you. Thank you very much. So we finished on time. I want to make a few last-minute announcements. Number one, so all the excellent presentations today, very interesting cases. Remember, if you want to submit it to the Journal of Vascular Surgery case reports, if you do it by December 31st, 2024, that will be, and it gets accepted, that the MVS will pay for yours because you have to pay for that submission. So please do that. Lots of great cases. Second, please go visit the exhibit halls. They help us run the meeting. And third, be back at 3:15 for the New Horizons meeting, which is going to be focused on advocacy. Thank you very much.